pregnant persons are less likely to be fully vaccinated compared to non-pregnant persons, even though they're at greater risk for a severe disease from COVID.
We probably know more about these earlier in the life cycle of the vaccine than we ever have about any other vaccine, but there are still questions that people would like to know.
This has been, I think, one of the biggest myths and misperceptions of this entire pandemic.
But I think we should be really clear. The main reason that we want pregnant individuals to be vaccinated is because they are at high risk for severe complications if they become infected with COVID during pregnancy.
From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
I'm Dr. Linda Brubaker, Associate Editor of JAMA and Clinical Professor of Obstetrics, Gynecology, and Reproductive Sciences at the University of California, San Diego. I spoke with 3 experts about the rapidly evolving data around COVID-19 as it relates to pregnancy, breastfeeding, and fertility in the United States. I delved into this data further during a recent conversation with my colleague, Dr. Laura E. Riley, Chair of Obstetrics and Gynecology at Weill Cornell Medicine and Obstetrician and Gynecologist-in-Chief at New York Presbyterian Hospital.
We want birthing parents to focus on the care of their newborns, but also it's incredibly important for pregnant individuals to focus on their own health. Because I think what we really have learned very starkly during this pandemic is that pregnant individuals are at greater risk for severe COVID infection in the course of pregnancy and up until about 12 weeks postpartum. So it's very important for those individuals to be vaccinated as soon as they find out that they're pregnant if they haven't been vaccinated prior. There's more than enough safety data now available about the vaccine that I think people should feel reassured that the risk-benefit ratio would really strongly point to vaccination over any other concern about the safety of the vaccines.
We don't have much information about individuals who recovered from COVID during pregnancy and were vaccinated subsequently during that same pregnancy, but evidence is beginning to emerge that there is an enhanced ability for the pregnant person to transmit antibodies to their newborn.
For the few studies that have looked at antibody transfer during various trimesters of pregnancy, either from infection versus vaccination, all of those studies are pretty consistent that those antibodies are quite robustly developed. And those antibodies then are transmitted to the baby and can be found in cord blood of the newborn. There are antibodies found through breastfeeding as well. What is not known is what is the correlative protection, i.e. how much antibody that we're measuring is consistent with enough antibody to protect from infection. I don't think we know the exact number, but it's pretty clear that having some antibody is certainly way better than having none. So whether it's antibody through COVID infection versus vaccination, at the end of the day, what you want is some protection. We will start to get some of that data that you were just mentioning.
For a pregnant person who gets a COVID infection very close to delivery and the newborn is healthy, there's no reason to assume that the parent can't establish lactation simply based on the fact that they had COVID so close to delivery. Is that true?
That's true. I don't think that there's any data that would suggest that there's a problem with that. We certainly would actually encourage it because you want to provide as much protection to that newborn as you possibly can. And certainly antibodies in the breast milk has been documented. And so we would encourage those women to breastfeed.
And what precautions are being taken for those who want to establish lactation after delivery but are actively viremic?
We were very concerned about pregnant individuals who were actively infected at the time of delivery and then starting to breastfeed. And there was a lot of controversy about separating babies and could those individuals give COVID to their newborns. After some period of time of monitoring pretty good epidemiologic data, it suggests that that's a very unlikely scenario. And so really, we haven't been separating babies when pregnant individuals have gotten COVID around the time of delivery. If they're actively viremic, they may not be breastfeeding right away, but certainly soon thereafter, once they have those antibodies, you want the baby to get those protective antibodies.
Dr. Riley, if an individual has COVID at any point during pregnancy, but then recovers, is there any reason to think that they couldn't establish lactation or proceed with breastfeeding?
I don't think that there's any reason that a COVID infection should impede breastfeeding, assuming an individual recovers from the COVID infection. Our biggest concern with COVID infection during pregnancy is that some individuals will do extremely poorly and need ICU admission or intubation or ECMO or any number of very serious complications. And so for those individuals, I think that COVID infection may in fact truly impede breastfeeding or certainly make it much more difficult. But for the vast majority of people who are able to recover from COVID infection, there's no reason that their breastfeeding should be impeded.
Is there any reason that a pregnant individual cannot breastfeed after COVID vaccination during pregnancy?
No, there's no reason. I think that we have spent lots of time trying to encourage breastfeeding for, as we talked about, for all sorts of reasons. I think that the benefits of COVID vaccine and the fact that we have now established that there are antibodies to COVID that can be found in breast milk, I think is just an added reason to continue to encourage vaccination for those who are lactating, just as we encourage vaccination for those who are pregnant.
Based on the information we have discussed, is there any advice you would have for a pregnant individual who has not had COVID and is trying to decide when in pregnancy they should receive their COVID vaccine?
I think that as we get more data about the benefits of vaccination during pregnancy, we do tend to focus on the benefits for the newborn. Mom gets vaccine during pregnancy or gets it while breastfeeding. The newborn definitely benefits from those antibodies. But I think we should be really clear. The main reason that we want pregnant individuals to be vaccinated is because they are at high risk for severe complications if they become infected with COVID during pregnancy and up until 12 weeks postpartum. So we really want pregnant individuals to protect themselves. So if they have not been vaccinated prior to pregnancy and they're in the first trimester, we want them to be vaccinated against COVID in the first trimester to prevent that severe illness. And if they were vaccinated prior and need to be boosted because they're past 6 months from their primary series, again, we want that booster shot to happen early in pregnancy if that's appropriate or in mid portion of pregnancy and not wait until the third trimester or wait until they're breastfeeding for the sake of their newborn. Because really the vaccination is to prevent that severe COVID infection during pregnancy.
Dr. Riley, on a different note, we know there are racial and ethnic disparities in maternal and fetal health. How does COVID-19 and vaccinations for COVID-19 factor into this?
I think that this is yet another example of where there are racial and ethnic disparities in maternal health. And severe COVID infection is preventable if individuals are vaccinated. And the fact that that happens at a significantly lower rate in Black and Brown populations is particularly upsetting. And I do think that it does add to the racial and ethnic disparities in maternal morbidity as well as mortality that we see now and will see going forward. It also underscores the need to continue to prioritize vaccine education and access, particularly for those populations.
Dr. Laura Riley, thank you so much for talking with us about the importance of maternal health and COVID-19 vaccination during pregnancy and postpartum. Next up, I had a discussion with my colleague, Dr. Christina Chambers. I sought out a conversation with Dr. Chambers, given her phenomenal expertise on breastfeeding, breast milk, and the incredible contribution she's made in her NIH-funded research. Dr. Chambers is a professor in the Department of Pediatrics with a joint appointment in the Department of Family and Preventative Medicine, Division of Epidemiology at University of California, San Diego. We know about the general benefits of breastfeeding. Dr. Chambers, can you tell me a little bit about how the COVID-19 pandemic may have impacted this?
The pandemic certainly has impacted decision-making about breastfeeding in many ways. Early on in the pandemic, there were concerns on the part of breastfeeding individuals who were starting to breastfeed, initiating this right after delivery, or who were continuing to breastfeed. There were concerns about whether or not the breast milk itself could be a source of infection. So a big question mark in terms of should I be breastfeeding at all if in fact I have a COVID-19 infection, that I might be introducing that infection to the baby. Certainly, the evidence unfolded in the ensuing months that there is evidence to the contrary, that replication-competent virus, meaning virus that could infect the baby, is not found in breast milk of infected women, either close to the time they test positive or are symptomatic or thereafter. So even though particles of virus can be found, replication-competent virus that actually could infect the infant is not. And so on the positive side of it, certainly the advice that many pediatricians gave to individuals who were breastfeeding or planning to initiate breastfeeding, that this would be a time not to discontinue breastfeeding, that this would be an opportune time and an important time to continue that source of nutrition.
Dr. Chambers, we know about the general benefits of breastfeeding, but does COVID-19 change anything about the safety of the breast milk itself?
Protection of the infant from infection from the breastfeeding individual, so through respiratory droplets and so on, precautions would need to be taken to prevent the infant from being infected through that route. But through the route of the milk itself, there is no reason to avoid using that milk. This question was raised importantly by donor milk banks all across the country. In the U.S. early on, there was concern that individuals who were donating milk that would be given to other infants might have been infected, maybe were asymptomatic and didn't know they were infected, and that milk itself could cause harm to the individual infant or toddler who was receiving it. However, there has been some work done to test the hypothesis that even if there was replication-competent virus in the milk, that the pasteurization process that donor milk banks use to clear anything of concern from the milk, that heating of the milk actually destroys the virus, even if you spike the milk with virus. So both donor milk side of things, as well as the individual who's breastfeeding their own infant or toddler, there doesn't seem to be any reason to avoid using that milk.
As of February 2022, we don't yet vaccinate children under 5 years of age against COVID-19. If vaccination in a pregnant person before delivery or after delivery doesn't impede breastfeeding, it currently may be the most reliable way to give that newborn some protection against the SARS-CoV-2 virus. Would you agree with that, Dr. Chambers?
I completely agree with that. I think there still will be reason to want to collect the evidence that infants or toddlers who are being breastfed by vaccinated individuals are protected, have a lower risk of developing a COVID-19 infection. Barring the time that it's going to take to collect that information, that everything we understand right now suggests that the benefits of vaccination for both the mother and the benefits of breastfeeding for the baby point to the recommendation that vaccination be given.
Dr. Chambers, could you summarize the key research areas that still need to be investigated?
One of them is how long does the antibody or antibodies, IgA and IgG, persist in milk after each dose of the vaccine? And does that vary by individual, depending on characteristics of that individual or underlying conditions that might interfere with or modify the immune response? So how long is that protection provided? I think from a biological perspective, we would really like to understand how those antibodies protect the infant. If the assumption is that these large molecules, when they get into the baby's digestive system, are likely broken down and don't result in elevated antibodies in the infant's serum or bloodstream, is this protection being provided by the presence of antibodies in the infant's saliva, in the GI tract, and so on? So I think that's an important question from the standpoint of understanding mechanisms. There are important questions, I think, also about brand. And so we've all heard discussions about the differences between the various vaccine formulations and how often they're given and so on. Understanding, are we getting similar or different antibody responses based on the different type of vaccine that is given while breastfeeding? I think that's an important question. And would there be one or more that would be more or less preferable if it was obtainable during that time window? We probably know more about these earlier in the life cycle of the vaccine than we ever have about any other vaccine, but there are still questions that people would like to know. Are there any long-term consequences or any differences in infants or children who were breastfed by individuals who were vaccinated during that time frame? And I think that data is obtainable. We're in the process of gathering some of that ourselves right now to look at short and long-term neurobehavioral and growth of infants or toddlers who are breastfed by vaccinated individuals.
Thank you, Dr. Chambers. It's been great to talk with you about the benefits and risks related to COVID-19, vaccinations, and breastfeeding, and what is the best way to think about the current data we have. Let's turn now to a conversation I had with Dr. Denise Jamieson, the chair of the Department of Gynecology and Obstetrics and the chief of Gynecology and Obstetrics for Emory Healthcare. I wanted Dr. Jamieson to role-play some common clinical scenarios with me related to COVID-19 vaccination and pregnancy. Dr. Jamieson, would you tell us a little bit about yourself?
I'm a practicing obstetrician gynecologist. I've been practicing obstetrics at Grady here in Atlanta for about 24 years now. I'm also the chair of gynecology and obstetrics at Emory University School of Medicine. And since the beginning of the pandemic, I've been lucky enough to be serving on the American College of OBGYN COVID working group that meets regularly to talk about COVID guidance.
Understandably, patients still have a lot of questions about COVID-19 and may not be up to date on all the latest news. I suspect you are hearing from colleagues across the country and certainly in your own institution about the common clinical questions that patients are asking.
Yes, it seems like every day there's a new question or a new twist on an old question. It's understandable that as things are evolving so quickly, it's really hard to keep up. And I know many of my patients and colleagues also are challenged trying to keep up with all the latest evidence.
Well, let's talk about a few clinical scenarios. I'm just going to pretend that I'm a primary care patient and I'm deferring COVID vaccination because I'm concerned that it will interfere with my efforts to become pregnant. What would you say to me?
This has been, I think, one of the biggest myths and misperceptions of this entire pandemic. At least it's the one that I hear the most about. And I think it's important to go back in time and understand where this came from and then understand the science behind this. There was a blog post that said that because the spike protein of SARS-CoV-2 and a placental protein called syncytin were similar, the vaccine, which targets the spike protein, could interfere with pregnancy and could make it more difficult to become pregnant. We have a number of lines of evidence, including some very recent evidence, that there is no merit to this claim. First of all, convalescent serum from patients with COVID doesn't interact with this syncytin protein. Secondly, there haven't been any fertility issues that were noted in the initial animal studies on vaccine safety. The third line of evidence is that even though pregnant persons were excluded from the early trials, there were still inadvertent pregnancies that occurred, and they occurred at similar rates in both arms. So various lines of evidence suggest that this is not true, that the vaccine does not cause infertility. The most recent information looked at pregnancy rates among couples trying to conceive, and it does seem like COVID infection decreases your chances of getting pregnant for a short period of time. But the vaccine does not. So even more direct scientific evidence that COVID vaccination does not cause infertility.
For individuals who may have distrust based on a group identity, may have distrust of government, distrust of how their group has been treated in past research, and especially for those groups who are already disproportionately affected in terms of maternal morbidity and mortality, how would you address those groups with special emphasis and encouragement to consider vaccination even before they become pregnant?
I think that it's understandable that people are hesitant to get vaccinated These are new vaccines. This is a newly identified infection that we didn't know about a few years ago. One of the things that I'm concerned about is that the rates of vaccination are lower, as you mentioned, in some groups. So overall, pregnant persons are less likely to be fully vaccinated compared to non-pregnant persons, even though they're at greater risk for a severe disease from COVID. Furthermore, even amongst pregnant persons and non-pregnant persons, there are variations by characteristics such as race and ethnicity. And the specific concern is that some of these same groups who are hesitant to be vaccinated are also disproportionately affected by other maternal health disparities, such as maternal mortality. And so this may exacerbate existing disparities in health and in maternal health. I think it's really important to ensure that you speak to your patients and that people understand and have their questions answered, and that we are upfront about what we know and what still remains to be answered regarding these vaccines.
I imagine that this conversation may require extra time, effort, focus, and may need to be repeated without undue pressure to allow an individual time to consider their views, their perspectives, and make their decision, but that the clinician has an ethical and moral duty to help to reduce those unacceptable health disparities.
I think it's really important to ask questions, to ask, are you vaccinated? Are you planning to be vaccinated? If not, what are your concerns? And to keep bringing it up. I have found that unlike some other vaccinations, such as influenza, there seems to be a little bit more flexibility in terms of more people changing their mind. I think because this is a new vaccine, because there's new information emerging literally every day, I think people seem to be a little more open to changing their mind. And so we don't want to lose any opportunity to help people make good decisions.
So let's move on to the clinical scenario where the clinician would be speaking with a pregnant patient who's indicating reluctance to get a COVID vaccination, expressing concerns that it may harm the baby.
Fear of harming the baby, fear of the effects of the vaccine on the baby. I think it's important to frame it in several ways. One is we know there are adverse effects of COVID infection on pregnancies. Pregnant persons who are infected with COVID have an increased risk of preterm birth, stillbirth, perinatal death. And so those known risks of COVID infection in pregnancy have to be weighed against any potential risks of the vaccine. And in terms of any potential risks of the vaccine, we now have a lot of data that are reassuring. Over 180,000 pregnant persons are included in the V-Safe surveillance system that's run by the CDC with no concerning safety signals. And the variety of pregnancy outcomes that are being looked at, such as spontaneous abortion or miscarriage, preterm birth, small for gestational age, all of those outcomes are similar to baseline rates. So no increased risk of adverse pregnancy outcomes from the vaccine.
So let's move on to your next patient who is asking which of these vaccinations is the best one for me. How would you advise them?
That's a really interesting question, and I think the answer to that question has changed relatively recently. So we now have some evidence that the mRNA vaccines are really a better vaccine for most people compared to the adenoviral Johnson & Johnson Janssen vaccine. And that's for several reasons. One are some safety concerns. There is a rare syndrome, thrombosis with thrombocytopenia syndrome. It doesn't happen often, happens about 10 per million doses of adenoviral vaccine given, but it does seem to be caused by the Johnson & Johnson adenoviral vaccine. In addition, what many of us saw and noticed, and now there are data, is that the mRNA vaccines, Moderna or Pfizer, do seem to work better. They do seem to be more effective. And so the recommendation now is that the mRNA vaccines are preferred over the Johnson & Johnson adenoviral vaccines.
How would you respond to a patient who asks, can you pass a COVID infection on to your fetus?
The answer is yes, it's possible, but it doesn't occur often. It's rare. Fetuses who are exposed in utero, so they get the infection once born, they do fairly well. Overall, they do on average better than higher risk adults. Because they're young and vulnerable, they still don't do as well as older children. And I think this really stresses the importance of pregnant persons ensuring that they're fully vaccinated to really avoid this risk and ensure that their babies are born healthy.
Dr. Jamieson, thank you so much for taking the time to speak with us. You offered up some excellent guidance for patients and clinicians related to frequently asked questions around COVID-19, vaccines, and pregnancy. Pregnancy and the postpartum period are such important times. The appearance of COVID has raised anxiety, and the evolving evidence gives us an opportunity to provide guidance and reassurance as more evidence and research comes forward in this area. For our listeners, a reminder that evidence and recommendations change. The information and recommendations in the podcast are appropriate in most circumstances, but they are not substitutions for expert medical counseling. For specific information concerning your personal medical condition, JAMA recommends that you consult your clinician. Additional information about this topic can be found in the related patient page, MedNews article, and a JAMA video. Links to all of these are also provided in this podcast description. You can find this collection at ja.ma/COVID and pregnancy. This episode was produced by Shelley Steffens at the JAMA Network. The audio team here also includes Jesse McQuarters, Daniel Morrow, Lisa Harden, Audrey Foreman, and Marilyn Firkala. Additional editorial guidance was provided by Jesse McQuarters, Director of JAMA Digital Media Production, Jennifer Abbasi, JAMA Associate Managing News Editor, and Elena Guabita, Video Producer and Editor on the JAMA Multimedia team. Dr. Robert Golub is the JAMA Executive Deputy Editor. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.